MESL refers to hepatic statuses in patients with at least one cardiometabolic risk factor. MASH is a more active form with inflammation and ballooning change. The cardiometabolic risk factors are shown here. They include obesity, glucose abnormalities, hypertension, and dyslipidemia. MESL is a disease spectrum. It ranges from simple statuses to steatohepatitis and fibrosis. And in some patients, it can eventually progress to cirrhosis and hepatocellular carcinoma. From a hepatology perspective, fibrosis is the most important predictor of prognosis. In this study, mortality risk increased as liver disease became more severe. The risk was already a little higher in simple statuses, but it increased much more once fibrosis developed. And it was highest in cirrhosis. So the message is simple. In MESL, fibrosis stage matters much more than statuses alone when we think about long-term outcomes. That is why in clinical practice, we focus much more on fibrosis staging. With that background, let's move to semaglutide. Semaglutide has several metabolic effects that are relevant in MESL. It reduces appetite and body weight, improves insulin resistance, and may also improve hepatic statuses and inflammation. Most of these benefits are probably indirect rather than direct. Semaglutide mainly works through appetite suppression and delayed gastric emptying, leading to significant weight loss. This in turn improves insulin sensitivity, reduces adipose tissue, and lowers hepatic fat accumulation and inflammation. There may also be direct hepatic effects, such as reduced de novo lipogenesis, less ER stress, and intense autophagy. However, the clinical relevance of these direct effects is still not fully established. The phase 3 ASCENT trial was a major turning point in the field. In patients with non-cirrhotic MASH and F2 to F3 fibrosis, semaglutide significantly improved both of the key histologic endpoints. First, MASH resolution without worsening of fibrosis was achieved in 63% of patients, compared with 34% in the placebo group. Second, improvement in fibrosis by at least one stage without worsening of steatohepatitis was seen in 37% versus 22%. So, this trial suggests that semaglutide is effective in improving inflammatory disease activity with a modest effect on fibrosis. We are seeing similar signals with dual agonists as well, such as tirzepatide. In a synergy NASH trial, tirzepatide showed a strong effect on MASH resolution with a clear dose-response pattern. However, when we look at fibrosis, the benefit appears more modest and less consistent. So, incretin-based therapy is clearly evolving fast, but the fibrosis gap has not been fully solved yet. Beyond clinical trials, emerging real-world data also suggests possible benefit. Here, I will briefly introduce two retrospective studies. This real-world study from the MGB health system compared GLP-1 receptor agonist with DPP-4 inhibitor in patients with MESL and type 2 diabetes. The main outcome was progression to high-risk fibrosis, defined as a fibrosis 4 index greater than 2.67. GLP-1 receptor agonist use was associated with a significantly lower risk of fibrosis progression with a hazard ratio of 0.75. The main implication here is disease stabilization rather than true fibrosis regression. In other words, GLP-1 receptor agonists may help to slow fibrosis progression, and this effect appears to be consistent across BMI groups. Using a very large EHR-based data set, the investigators examined major adverse liver outcome, short-lived MALO, in patients with MASLD and type 2 diabetes, including cirrhosis, decompensation, and HCC. Compared with DPP-4 inhibitors, semaglutide and tirzepatide were associated with a lower risk of these events. These findings suggest that incretin-based therapies may have clinically meaningful liver benefits in real-world practice. This slide shows how quickly the field changed. In 2024, guidance was still cautious because phase 3 histologic evidence was lacking. But after ESSENCE trial, semaglutide moved rapidly into clinical practice, with FDA approval in August 2025 and EU conditionally authorization in March 2026. So this is really a story of rapid translation from evidence to implementation. The American Association also recently updated its practice guidance regarding semaglutide therapy for MASH. Based on this guidance, semaglutide can be considered in patients with moderate to advanced fibrosis, especially those with F2 to F3 disease. And importantly, fibrosis assessment does not have to rely on liver biopsy. Non-invasive tools such as VCTE, known as FibroScan, MR elastography, and the ELF test can also be used in clinical decision-making. For patients with cirrhosis or concomitant active liver disease, the use of semaglutide is not recommended. What is also helpful is that the guidance provides a practical framework for monitoring treatment response. For example, changes in liver stiffness or ALT over time may help us judge whether treatment is working and whether continuation makes sense. That kind of response-based approach is very relevant in real-world practice. Of course, semaglutide is only one part of a broader incretin-based treatment landscape. Dual or even triple agonists may achieve greater weight loss, in some cases approaching 20 to 25%, and potentially stronger hepatic effects. We still need more mature data, but these agents are likely to further expand treatment options in MASH patients. Of course, semaglutide also has its limitations. One challenge is maintaining the benefit over time. This slide shows data from the Step 1 extension study where semaglutide was stopped after 68 weeks and patients were followed for another year. During treatment, weight loss was substantial, but after withdrawal, much more that benefit was lost. In fact, patients regained about 2/3 of their prior weight loss, and many cardiometabolic improvements also drifted back toward baseline. So the message here is that semaglutide is effective, but durability depends on continued treatment. That is why obesity is considered as chronic relapsing disease. Second, there is still a clear fibrosis gap. Even in ESSENCE trial, the anti-fibrotic effect was more modest than the effect on steatohepatitis, and a substantial number of patients still did not achieve a meaningful fibrosis response. So going forward, we need a better understanding of who responds well and who does not. And cirrhosis is mostly irreversible stage. The use of semaglutide is not recommended in this group. Third, muscle loss is another consideration. Emerging data suggests that semaglutide is associated with lean mass loss, accounting for a meaningful proportion of total weight reduction. Therefore, attention should also be paid to preserving muscle mass through adequate protein intake and regular resistance exercise. For patients with non-obese MASH, semaglutide use should be cautious because it is highly likely that they already have sarcopenia at baseline. Lastly, safety and tolerability are also important. Rapid weight loss may increase the risk of gallstones. There have also been reports of a possible association with pancreatitis, although this remains controversial. In patients with diabetes, careful monitoring for diabetic retinopathy is recommended, especially in those with pre-existing disease. So where does semaglutide fit in real-world clinical practice? The most appropriate candidates are patients with non-cirrhotic MASH and F2 to F3 fibrosis, because this is the population with the strongest evidence to date. It may be particularly useful in MASH patients with major metabolic comorbidities, especially obesity and even more so severe obesity. It may also be especially relevant in patients with type 2 diabetes, where the metabolic benefit is likely to be even more clinically meaningful. To summarize, semaglutide has clear therapeutic promise and pitfalls. Its strongest effect is one steatohepatitis improvement and disease stabilization, especially in moderate to advanced fibrosis. However, its antifibrotic effect is more limited, and this becomes even more important in advanced chronic liver disease. Another challenge is long-term maintenance, as treatment discontinuation may lead to substantial weight regain. I will conclude my talk today. So semaglutide is the first GLP-1 receptor agonist to show phase 3 histologic benefit in MASH, especially in patients with F2 to F3 fibrosis. Its major strength lies in improving steatohepatitis, while its benefit on fibrosis, although meaningful, is more modest. It should therefore not be viewed as a universal antifibrotic therapy, particularly in cirrhosis where evidence remains still limited. Ultimately, the key, timely intervention and careful patient selection among MASH patients. Thank you very much for your attention.